right, we are going to go ahead and get started. It is great to see everyone on this Tuesday morning. Welcome to the Department of Psychiatry and Behavioral Sciences Grand Rounds. My name is Dr. Eric Hung. I am the Residency Program Director in the department, and I also happen to be the co-chair for our Trainee Grand Rounds Research Awards. I will say, having co-chaired this with Dr. Vogelmeyer for the past several years, it has just been incredibly impressive to see the work that our trainees across the department are doing with respect to scholarship and research. And today marks sort of our second day of celebrating the outstanding work that our research trainees are doing. It's my pleasure today to be able to introduce Dr. Kristen Nishimi and Dr. Aifa O'Donovan as one of our presentations, and then Dr. Shuyu Wang and Dr. Dave Manoli as our second presentation. I'm going to hand the floor over to our first mentor to be able to introduce our first trainee. And Dr. Aifa O'Donovan, thank you so much for being an outstanding mentor, and I'll turn the mic over to you.
Thanks so much, Eric. Good morning, everyone. Thanks for being here so bright and early. It is a true honor to introduce Kristen Nishimi, who is a brilliant scientist and also just an exceptional human being who's completely dedicated to reducing health disparities and increasing social justice through her work and her life. And to give you a little bit of her background, she did her undergrad at UC Berkeley, just over the bridge, in psychology. And then we were really fortunate to have her come to the San Francisco VA and UCSF as a lab manager, where I think she started her work on trauma and PTSD. And she went on to get training through an MPH and a PhD in population health sciences at Harvard, where she completely excelled and has been exceptionally productive. So already as a postdoc, she has 29 publications, including recent papers in PNAS and JAMA Network Open. And her work is just of exceptionally high quality, extremely thoughtful, and highly programmatic. So she's really building a story and a picture about how trauma affects health and has great potential to make a real impact on public policy and healthcare. We were really fortunate again when we lured her back to UCSF in the Bay Area in 2020, not only I think because of the winters on the East Coast, hopefully not, but when Kristen started, so it was June 2020. I don't know if anyone remembers that time, but it was a really interesting time in the world, and Kristen decided to throw herself into work that we had started on trauma and the COVID-19 pandemic. This is exceptionally challenging work. It's a bit like building a ship while sailing the ship, except you're also sailing in a storm. And Kristen has excelled in her ability to tackle big questions about the pandemic and how it's affecting mental health and how mental health is affecting outcomes. So today you're going to be able to hear from her a little bit about this work and about work that she's done at a large scale with VA data, and also with a study that she leads, which is focused on the experiences of people with PTSD over time during the pandemic. So without further ado, Kristen, I'm going to pass over to you, and I look forward to hearing your talk.
Thank you so much, Aoife. And thank you for your mentorship, of course, as well. And thank you to the department for allowing me to be here and present. So I'm gonna share my screen and get started. Okay, so let me know if that's not looking good. Okay, great. So as Aoife noted, I'll be presenting on post-traumatic stress disorder and its relationship with behaviors and physical health in the COVID-19 pandemic. So PTSD is a psychiatric condition that can develop following exposure to a traumatic event, and it's characterized by re-experiencing symptoms, avoidance, negative thoughts or feelings, and hyperarousal. And it's been linked to multiple physical health conditions, including cardiovascular, metabolic, and musculoskeletal disorders. So in the context of the COVID-19 pandemic, it's possible that pre-existing PTSD could increase vulnerability to negative COVID-related outcomes via similar psychological, behavioral, or biological pathways. So as noted, we kind of shifted from working on understanding impacts of PTSD on these sorts of chronic physical health conditions to examining how PTSD may be influencing health during the pandemic. And so I'll share some of those studies today. So multiple studies and now actually several meta-analyses have shown that that pre-existing psychiatric disorders increase the risk for negative COVID-19 sequelae, including hospitalizations, ICU admissions, and mortality. And consistent evidence across these studies actually prompted CDC to include mental health disorders, and specifically mood and schizophrenia spectrum disorders, on their list of conditions that are associated with increased risk for severe COVID back in October of last year. However, none of these studies have specifically focused on PTSD. Therefore, the risks for severe COVID associated with PTSD remain unknown. So there are several reasons why PTSD specifically could increase the risk for severe COVID outcomes, as PTSD has been consistently associated with medical comorbidities that have been shown to increase risk for more severe COVID, including things like heart disease, hypertension, obesity, diabetes, and chronic lung diseases. PTSD has also been associated with an increased propensity to engage in poor health behaviors, such as smoking or physical inactivity, or other risky or deleterious behaviors that could increase one's likelihood of contracting COVID. And chronic PTSD has been linked with systemic inflammation, as indicated by higher levels of circulating pro-inflammatory cytokines in combination with low cortisol, which actually reduces inflammation normally, as well as dysregulated immune functioning, as indicated by alterations in immune cell counts and earlier evidence of immune system aging. And all of this might influence the risk for both contracting COVID-19 and for more severe outcomes once contracted. So we were interested in examining whether PTSD specifically was associated with an increased risk for severe COVID outcomes, similar to how prior work has shown this among other psychiatric disorders. So to look at this, we used clinical and administrative records from over 220,000 patients who accessed Veterans Healthcare Administration care nationwide through August of 2021. And so everyone in our sample had received a positive SARS-CoV-2 test, either at the VA or elsewhere, and then that positive test was recorded in VA clinical notes. Our primary predictors were derived from clinical records and included whether individuals had a diagnosis of PTSD, either with or without any other comorbid psychiatric disorder, another psychiatric disorder besides PTSD, including things like depression, substance or alcohol use disorders, and bipolar disorder, or if they had no psychiatric diagnoses in the past 5 years. And our outcomes were any hospitalizations or deaths within the 60 days following that positive test. And so we adjusted for sociodemographic covariates and medical conditions, including heart disease, diabetes, COPD, and cancer, as well as smoking status. We used generalized linear models to derive relative risks for these two outcomes separately. And then we decided to stratify at age 65, given that age is such a strong predictor of poor COVID outcomes. So here are some descriptives of our analytic sample. So patients were about 60 years old on average. Almost 90% were male, which is consistent with national VA patient populations. And notably, about 72% had at least one of the medical comorbidities that we assessed, and 61% were current or former smokers. About a quarter of patients had a clinical diagnosis of PTSD in the past 5 years, and another quarter had other psychiatric disorder diagnoses. And then regarding our outcomes, among these patients, 15% were hospitalized and 6% died in the 60 days following that positive SARS-CoV-2 test. So here are the associations we found between PTSD and other psychiatric disorders with our outcomes, adjusting for only sociodemographic factors and relative to that group with no psychiatric disorders. So among these younger patients, both PTSD and other psychiatric disorders increase the risk for hospitalizations and for deaths, and largely to a similar extent or magnitude. Whereas among older patients over 65, Although PTSD did increase risk for both of those outcomes, other psychiatric disorders actually increased risk for these outcomes to an even greater magnitude. And when we additionally adjusted for medical conditions and smoking, we can see that the effects were attenuated across associations. However, PTSD and other psychiatric disorders remain significantly associated with hospitalizations among all patients and with deaths among those over 65, even when accounting for these medical comorbidities. So as a follow-up to explore which of those other psychiatric disorders might be driving associations, we examined each of the individual disorders in their own models. So for risk of hospitalization, alcohol use, substance use, bipolar, and psychotic disorders seem to be associated with relatively high levels of risk. Whereas for deaths, bipolar disorder and psychotic disorders seem to be conferring the highest levels of risk. So in using this VA COVID data, we were likely not capturing all patients who had positive SARS-CoV-2 tests outside of the VA or those who weren't tested. We also lacked detailed socioeconomic or other demographic data that could have been additional confounders in our models. And these results have relatively limited generalizability beyond a VA patient population. However, our findings do suggest that pre-existing PTSD may increase the risk for more severe COVID outcomes, even when taking into account medical conditions. And while PTSD may not increase the risk to the extent of some of those other disorders, especially among older adults, PTSD remains an important mental health condition that should be considered among that full range of psychiatric conditions that are noted to increase risk for severe outcomes. So given those results, we then wondered how psychiatric conditions might be influencing risk for contracting COVID-19 to begin with. Particularly now that vaccines and boosters are widely available, how might these pre-existing mental health conditions influence breakthrough infection risk? So several early studies before vaccines were widely available had indicated that psychiatric conditions increased risk for contracting COVID on average. And additional prior evidence against other infections like influenza and hepatitis B have suggested that mental health and chronic stress can impair responses to vaccine and lower vaccine efficacy. But there was little data on whether psychiatric disorders influenced COVID infection risk among those who are already vaccinated. So through the summer and sort of early fall of 2021, we began to see both increases in vaccination, but also increases in breakthrough infections. So we therefore examined whether psychiatric disorders were associated with breakthrough infection incidence during this time. So we again used national VA clinical and administrative data, creating a separate cohort of over 260,000 patients nationwide who accessed VA care and were fully vaccinated. So they were all at least 2 weeks past the full regimen of either 2 doses of an mRNA vaccine or 1 dose of J&J. And our primary predictors, again, were PTSD and other psychiatric disorder diagnoses. And the outcome was a breakthrough SARS-CoV-2 infection, defined as any positive test, either at the VA or later recorded at the VA among these fully vaccinated individuals. We adjusted, again, for sociodemographic factors, medical conditions, and smoking, but also included vaccine type and time since full vaccination. And we used generalized linear models to estimate the relative risks, and also stratified by age, as it's a critical risk factor for breakthrough infection as well. So here are the associations we found between psychiatric disorders and breakthrough infection incidence, adjusting for all of the covariates. So you can see that in older patients, most psychiatric disorders were associated with elevated risk above and beyond demographics and comorbid medical conditions and smoking. Whereas in younger patients, only a few of those individual disorders were significantly associated with increased risk. And then interestingly, while psychotic disorders increased risk in older patients, this diagnosis appeared protective against breakthrough infection among the younger patients, though the reasons for this are not entirely clear. And so further research will be needed to clearly understand this. So in addition to the limitations I noted in that prior analysis, for this study in particular, we only included VA patients who had a record of their full vaccination in VA clinical notes. So we may not be including other fully vaccinated individuals. And relatedly, the breakthrough infection outcome is likely underestimated, as we may be missing cases that were asymptomatic or not tested or that were assessed elsewhere. So in this analysis, we identified that PTSD, as well as other psychiatric disorders, were associated with a modestly increased risk for contracting breakthrough infections. And additionally, the associations of psychiatric disorders with breakthrough infection appear to be stronger among older versus younger adults, which can help us identify groups in the population at highest risk and sort of target prevention efforts. So while we were able to access this incredible data source made possible through VA, which has enabled a lot of incredibly important research on COVID, a limitation of this large-scale EHR work is that we cannot easily disentangle mechanisms. Therefore, we supplemented this work with analyses from a small cohort, trying to understand some of those pathways linking PTSD with increased COVID risk. So we focused on some of the behaviors that have been so critical to controlling COVID disease spread, wondering if PTSD might be increasing COVID disease risk via engagement in these behaviors. So prior work has suggested that PTSD is associated with an increased likelihood to engage in risky health behaviors. But PTSD may also influence greater engagement in protective behaviors for COVID via increased hypervigilance, threat sensitivity, or social isolation or social disengagement, all of which may actually be adaptive in the case of an infectious disease. So we wondered how PTSD might be related to protective and risky dimensions of COVID-related behaviors. We began a smaller community-based cohort during the pandemic, which included individuals who'd previously indicated interest in remote research related to trauma and traumatic stress back in 2017 and 2018. So in August of 2020, after the pandemic began, we contacted all 3,600 of these individuals and received a little under 900 completed online surveys as of wave 1. And we've since followed up individuals about every 6 months and have 4 completed waves of data collection, but I'm only presenting on waves 1 and 2 now. So this nationwide sample was about 37 years old on average and largely included women and those of high educational attainment. And consistent with the original study recruitment, about a third met criteria for probable PTSD on the PTSD checklist 5 as of our wave 1 assessment. So we asked about past month frequency of engagement in various protective behaviors against COVID-19, including wearing masks, washing hands, maintaining distance from others. And you can see there was relatively high levels of engagement in these behaviors as of the summer of 2020. So we also asked about several behaviors that would increase risk for COVID-19 that range from relatively more avoidable behaviors, such as taking a flight for vacation or attending large events, to those relatively less avoidable, including taking public transportation and going to grocery stores in person. And when we looked at associations between PTSD and average levels of engagement in these behaviors cross-sectionally at wave 1, probable PTSD was associated with relatively higher levels of both protective and risky behaviors. So it appeared that early on in the pandemic, individuals who had higher levels of PTSD symptoms seemed to engage in more protective and more risky actions relative to COVID-19. So this really made us wonder whether there were differing patterns of COVID-19 behavior engagement across our sample. So we looked at that list of both protective and risky behaviors and performed a latent class analysis to identify potential underlying groupings in the data. And we found 4 distinct groups. So 3 of the groups had relatively lower levels of risky behaviors, as seen in the red shades, where darker indicates more frequency. And so the first of these low-risk groups was labeled as highly protective, and they frequently engaged in most of the protective behaviors as shown in blue. The second was moderately protective, who frequently washed hands and wore masks, but had lower levels of the other protective behaviors. And the third was labeled minimally protective, who wore masks, but otherwise had low levels of both protective and risky behaviors. And then the fourth group was the smallest and had the highest levels of risky behaviors. However, they also had relatively high protective behaviors, indicating that these individuals may engage in some riskier actions, but also are compensating by being relatively protective. And when we examined the proportions of individuals with probable PTSD in each of these groups, consistent with that prior analysis of average behaviors, the groups with the highest risk, but also the highest protective engagement, had higher proportions of individuals meeting criteria for probable PTSD, while that minimally protective group had the lowest proportion. When we examined PTSD and the odds of being vaccine hesitant versus accepting as of wave 2, which was in March and April of 2021, we did not find a significant association, indicating that PTSD symptoms did not appear to be related to whether one received the vaccine or would be willing or not willing to get vaccinated. So these analyses were limited by use of self-report data, which may be subject to reporting or social desirability biases. And most of the analyses were cross-sectional, thus directionality can't really be teased out. And we had a relatively low response rate from that initial eligible sample, which could lead to selection biases, as well as limited generalizability beyond the sample that was mostly women who had high levels of trauma and PTSD symptoms. But despite these limitations, we did find that PTSD symptoms were linked to higher protective and risky behavior engagement. And additionally, COVID-19 behaviors seem to cluster in patterns, indicating that most people had low risk, but had varied levels of protective action, while some individuals seemed more risky, but appeared to compensate with more protective behaviors as well. And individuals with high levels of PTSD symptoms were overrepresented in both extreme groups. So those most protective, but also those most risky. And lastly, PTSD symptoms appeared to be largely unrelated to COVID-19 vaccine intentions. So to briefly summarize across those findings, PTSD may increase vulnerability to negative outcomes during the pandemic. So individuals with PTSD may have more severe disease outcomes than those without mental health disorders, and they may be at heightened risk for contracting breakthrough infections. So this indicates that potentially targeted prevention or screening efforts should be considered for these groups. And research should also examine how PTSD impacts long-term health outcomes during the pandemic, including risk for long COVID. And we did find that PTSD symptoms were linked to more risky COVID behaviors, but also to more protective behaviors, and they were unassociated with vaccine intentions. So engagement in risky behaviors may be one potential mechanism explaining these increased negative sequelae as seen in individuals with PTSD, but other important psychological, biological, or environmental factors may also be mechanisms underlying this increased risk and should be examined in future work. And with that, I'll again thank my mentor, Aoife, as well as all of my other mentors and collaborators who've contributed so much to this work. And I'll also thank the veterans and community members who contributed their time and data to this research, and the VA for supporting my postdoc, and the department here again for allowing me to present. And with that, I'd love to take any questions.